Imaging in the Heart, Part 2. I'm going to pick up where we left off, and what I wanted to do is try to introduce you a little bit to the concepts of cross-sectional anatomy, and specifically what you're looking at here is an MRI that is in what is called the long axis. That's the one that's to the left, and a CT scan. This is a slice that is further inferior to the one to the right, to the left, and again, it's axial. Couple of things about this. First of all, what you're looking at right here is the vertebral body on this MRI. There's the vertebral body right there. So this is telling you in both of these cases what you're looking at here overall is posterior. Let's see if it's going to let me write this. Okay. So back in here, this is all posterior. Now these are axials. That means that what you have up above it here is all anterior. Now the way you can kind of tell that, of course, obviously, is the vertebral bodies. The other thing I want to point out is there's the sternum in this case. Same thing here. You see this bony detail? There's the sternum. Now the MRI is not in a complete axial projection. In other words, the patient's laying flat on their back, and what you are looking at is almost like a slice of bread out of a loaf. This is actually angled some. And the reason that I know this is that we are seeing the entire septa from one side to the other. Now, the heart is not in a perfect, orderly manner. You know that it is oblique, and it sort of tends to tilt downward inferiorly from over to the atria to the ventricles. So that's what's going on here. So what they actually call this is called a long axis view. This is a very, very common plane that is used, obviously, as you can see here, in MRI, but it is also used if you're looking at things, for example, in ultrasound, and to a lesser degree in nuclear medicine. Now here's the thing. This type of imaging is for the most part driven by cardiologists. They are the ones that are leading these, they're the ones that are ordering these. They want to see things set up in projections that they understand. So it makes sense that you would be consistent from one imaging modality to the other with regards to these different planes. So you have a long axis plane here. There's also a short axis, and we're going to be talking about that as well. Now, with regards to this particular MRI image here, a couple of things I want you to note. First of all, here, notice how very, very thin the myocardium is. This is part of the atria. Specifically, what you're talking about here is the right atrium. This is the interatrial septum, IAS, and then you've got the left atrium. Now remember, the left atrium is actually the posterior chamber, and that's, of course, exactly what you're seeing right here. They both look huge. A big part of the reason why they look huge is this is not a straight axial. Remember, this is at an angle, so it tends to exaggerate them a little bit. The other thing is you would expect that at some points both atria are going to be wide open prior to contraction of the heart, and it seems reasonable that's kind of what we're looking at here. Now, moving on, from the right atrium into the right ventricle, and you can see the little arrow here is pointing down to here. There is the interventricular septum right here, and there is the left ventricle. Now the ventricles do more work than the atria does, so it stands to reason that the myocardium will be greater. And not only that, but it's going to be greater over here to the left than it is to the right. In the right, remember, it's just pushing blood through this pulmonary circulation, pulmonary artery to lungs, pulmonary veins, back over to the left side of the heart. Systemic circulation is a very different thing. You're now pushing blood through, for example, the trunk of the body, the head, the extremities and all. It's much further distance, much harder work, much greater muscle. On the CT that you see here, what you are looking at here is further inferior than what you're seeing over here to the image to the left. What you're actually seeing is the right ventricle and the left ventricle only, because we're further inferior. There is the septa right here. So that's all you're seeing down here at this point. Now the book is pointing out here that you're seeing a little bit of the pericardium here, and that's fine. You can get fluid in between the layers of the pericardium. So if you look at the image that's over here, you can see there's the myocardium and all, and the pericardium, which is that kind of sac, is on the outside, and they have been separated from one another because there's fluid in there. Okay, this would be called a pericardial effusion. Anything that's a effusion is going to be a collection of fluid. This can happen for a number of reasons, including infections, inflammations. It can happen because of trauma. It can happen because somebody has an MI. Those are some of the most common reasons for something like this. The problem with this is that the fluid gets building up and building up. And the pericardium is a sac of fibrous material. It will stretch to a point, but then it won't stretch anymore. Now what happens is that the fluid builds up, the heart in turn is going to be compressed, which means you're not going to get good cardiac output. All right, on the Cine MRI, again, there's your vertebral body right there, so that tells you where posterior is. This is the left atrium, posterior back there. Right atrium, right ventricle, left ventricle, and that's going here towards the aorta. So there's the four chambers of the heart. Notice again the size of the myocardium in comparison between the atria and the right ventricle versus the left ventricle. Here's another stationary image. This is a CT scan. I want to call your attention to a few things here, including the prevalence of motion here. This was a relatively long scan time. As a consequence, the heart, of course, is continuously beating. Hence, you get a lot of motion artifact here. There is the pericardium. You can kind of see it here. And interestingly enough, over here, you can notice that it's very, very much thickened here. So we probably have a case of pericarditis. This is the myocardium here in the left side, and over here to the right side, and there's a lot of fluid in here. That is the pericardial effusion. Here's another one on MRI, kind of the same thing. You can kind of see what's going on from here to here. On echo, hey, let's do it all with days. Let's take a look at what we got here. Ultrasonography utilizes almost like sonar to send sound waves through, and when there's differences in tissues, that causes the return echoes. And some of the differences, of course, would be, for example, myocardium versus the blood flowing in the heart. Those are two very different things where echo is concerned. Notice in X-ray, we don't really have a way of differentiating that. So the presence or absence of fluid also kind of bounces back. And as you can see here, this is roughly speaking in that long axis view where you've got the septa right here to here. So we've got the right atrium, the left atrium. You can see where the right ventricle and left ventricle is. This is all myocardium. And unfortunately, there's this big old bunch of fluid that's kind of settling down in there. All right. Now, if we're talking and kind of getting back, I think, a little bit into the anatomy of all of this. And, you know, we've talked about this before, but it never slows me down from talking about it again, which is the flow of the heart. The image that you're seeing right there is a 3D CT. In essence, what this is a volume rendering of a CT scan. The arms, when the patient is laying in the scanner, are brought up above their heads. So as a consequence, as you can see here, there is the head of the humerus, ditto over here. You see how the scapula have been pulled away and all of that. They put an IV into somebody if they're going to use IV contrast, so it's usually going to be in the antecubital vein. In this particular case, it's from the right side. And what you're seeing here is the flow of IV contrast media through the venous system. And specifically in this area here, this would be all axial vein. Notice, by the way, those are the valves that you typically see in the extremities with regards to veins. You see those also in the lower extremities. But the contrast media is flowing through here, the area here now of the subclavian vein and brachiocephalic vein into the superior vena cava and on into the right atrium. Now this is a very, very, very thick reconstruction. One of the things you can see here is that the sternum itself is actually overlaid over the heart, and I venture to say we're thick enough, we're looking at posterior ribs. This is pretty thick, but that's why it's three-dimensional. So the flow is going to start through the vena cava, and you have both the superior and the inferior. Both are going to flow into the right atrium. And as you're probably aware, it's going to start flowing through the right side of the heart into the pulmonary circulation, back to the left side of the heart, out into the systemic circulation. When we look at it, the heart, because we've really talked about that, when we look at the structure of the heart, I've already kind of commented on the fact that the right ventricle is the anterior chamber rather than over to the right. And this kind of gets back to the box concept. The left atrium is the posterior chamber. Well, what that leaves us really is the right atrium to the right side, the left ventricle to the left side up to a point, and the aorta is smack dab in the middle. And this is the case in the upper parts of the heart. Now, the septa that I was already kind of identifying to you and outlining, where's that thing? All right. The septa is pretty much kind of going along this way. Because remember now, the interventricular septum is separating out the right ventricle from the left, and the intraatrial septum is separating out the right atrium from the left. This is a very, very old CT scan. What I've done is outlined with blue the areas of where blood flow is going to be unoxygenated, that's the blue parts, versus the oxygenated parts, that would be the red parts. So, for example, it's going here into the right atrium, which is over here on the right side and minding its own business. It's here, just like on a chest x-ray. But it's going to flow into the anterior chamber here, which is the right ventricle. Again, there's the sternum. This is the anterior. Blood is going to flow up superiorly from here. So it's going to come out of this plane, goes up superiorly into the pulmonary arteries, into the lungs, gets oxygenated, and it's going to come back by way of the pulmonary veins, this way and this way. This is oxygenated blood now into the left atrium. Left atrium, it's going to go by way of the mitral valve into the left ventricle, and then of course into the aorta, where it's going to move up back superiorly again. That's the carousel of the heart. If you're looking at things from an axial perspective, essentially it is the four chambers of the heart moving around the origins of the aorta, the ascending aorta. Even from a picture like this, which is really kind of crummy, you can kind of see the same thing. Where here is the here is the right atrium to right ventricle. Actually, it's a little bit too superior, but we'll say right ventricle to left atrium to left ventricle, and from left ventricle over here into the ascending aorta, and to be absolutely fair, there's the descending aorta. How about here? Okay, what have we actually got going on here? Now, you don't see much of anything here, but where would a pacemaker go? Well, we've already talked about the fact that pacemakers go to the right ventricle. How about in here? Well, we would expect it to actually go from the right atrium into the right ventricle. Now, this is showing you the four chambers of the heart, and the way this is angled, because now this is an echocardiogram. Okay, the way this is echoed, we've got the aorta right here, and they're just sort of circling around. In essence, if we took this and kind of flipped it 90 degrees, because you can see what we've got here, okay? If we flipped it 90 degrees, it would look pretty much like the previous image here. So it's going that way. Now I want to call your attention to something else. It has the appearances that there is an opening in the interventricular septum between here and here. Okay? That is a congenital defect, and it's called the VSD, a ventricular septal defect. In other words, when we talk about somebody having a hole in their heart, classically what we're talking about, there's a hole either in the ventricular septum here or within the intraatrial septum between the two atria. Now the atrial septum, I think, is more common. The ventricular septum is less common but is more serious. I think you can kind of understand that if you have blood flowing back and forth between the right and the left ventricles, you're mixing up oxygenated and unoxygenated blood, and that can't do the munchkin any good. Alright, so we've kind of talked about this. Incidentally, because I got into an interesting discussion with Delta about this, notice that we cannot see either the right, well, we maybe can see a little bit of the right border of the heart, but we cannot see the diaphragm at all. That's because there's fluid up in here and everything. If you come over here to this one, we can see a diaphragm. The diaphragm that we are seeing is the same one that you're seeing over here. So what you are seeing is the left diaphragm. We don't see the right diaphragm here at all, any more than we see it on the PA. And the reason for that is the fluid is obscuring the border. This is back to the silhouette effect. Alright, so there's the 4 chambers of the heart in a axial, kind of a quasi 4-chamber axial. Now there's that ventricular septal defect that I was actually talking about. Obviously we got something out of the way here. This is kind of the classic picture that you see, the 4 box. Remember what I was talking about? You kind of go like this, and then you divide it in half again, and then you've got atria here on top, and atria here, and then you got ventricles down here. I'm too lazy to type right and left. You see the exact same thing here. So even though this is not, strictly speaking, the way it actually looks, for two-dimensional image purposes it serves to a point. If you have a ventricular septal defect, you can kind of see what's going to happen with something like this. Oxygenated blood from the left ventricle is going to come into the pulmonary arteries. So you're not going to get the benefit of enough of that oxygenated blood going here. So our patient, in a lot of cases, can be cyanotic. Cyanosis means that they have blue skin. It usually means it's because the body is hypoxic or poorly oxygenated. You can see that, for example, if you look at the mucous membranes and the beds of the nails and the like. Cyanosis is a dangerous sign because your patient is really not getting enough oxygen. Should be on O2 at the very least. Okay, there's the VSD with a sonography. Now, this is normal, and you can see there again is a reasonably nice intact VSD, ventricular septum. In this case, there's a hole there. The areas there that you see in blue is really the way sonography can record Doppler. Now, if you think about it, if a car is coming towards you, you can hear it coming towards you, and then if it passes you by and goes away, you can hear it going away. And you can tell the differences as it gets closer to you and as it moves further and further away. The reason for this is that the wavelengths of the sound change. They change as they come towards you. They change as they go away from you. And your ears are perfectly capable of picking up the differences in the wavelengths. After all, it's sound. Well, sonography and other modalities can pick up those same changes. Now, in this particular case, fluid, that is blood in this case, that is flowing from the left ventricle to the right ventricle is not going in the appropriate direction. So it is actually being recorded as, in a sense, as wrong direction. And that's why you're seeing that right here. You can also sometimes pick up turbulence, where, for example, there might be an atherosclerotic plaque that's slowing the blood down and causing it to kind of churn and things like that as well. Sonography is very, very good for something like this. And this is why echocardiography is a very, very important part of the arsenal for diagnosing cardiac disease. Here's another one. In this case, this is an MRI. And the reason I've included this is because the myocardium is hugely out of whack here in terms of size. There's the VSD right here. Now, let's kind of talk a little bit what's going on here. First of all, there's your right atrium. There is a rather large left atrium. Here's your right ventricle. And there's your left. So we got the bunch of them right there. Now, because of this VSD, fluid, blood, is flowing back this way, and as we just talked about, it's going back up into the pulmonary arteries. That means that the patient is hypoxic, is in a high cyanotic state. Well, the body is perfectly capable of metering the oxygen levels. Now, remember, there's things called carotid sinuses and things like that. There are bundles of neurofibers that are really kind of, in a sense, monitors. And if you are hypoxic, one of the things the body's going to try to do is to try to improve that state. One thing you can do with it then is to increase the number of contractions and the strength of the contractions of the heart. Now, if this happens over a brief period of time, nothing's going to change with the myocardium any more than if you decide to go out one day and start working out, you're going to see any changes in your muscles or your biceps. But if it goes on for long periods of time, you can expect that you're going to end up with ventricular hypertrophy. The muscles themselves, the myocardium, are enlarging. So our patient in this case has an enlarged heart, in big part because the myocardium itself is huge. Okay? And that's why that's happening here. So this is a reactive thing on the same idea as if you were out there working out and, pumping those 15-pound weights or whatever it is that you do, and you could develop, deltoid muscles and biceps. Same thing's going on here. Now there's another issue potentially going on here as well, which is the size of this left atrium. I'm not entirely sure how to speak about that except for the fact that it just looks big to me. There may be other things going on. Okay, cardiomegaly, or an enlarged heart, as we've talked about, can be caused by a number of different things. It can be caused by enlarged muscle. It can be caused by a pericardial effusion. It can be caused by big dilated chambers inside the heart. We can't tell these things on a plain chest x-ray because there is no difference here between myocardium versus fluid versus blood. We don't see any of that. To do work and see anything requires that you put something in different, and that's exactly what they've done here. They've instructed the patient to drink barium, and what happens is the barium is going down the esophagus, and the esophagus is somewhat displaced because the left atrium is enlarged. Okay, there's a few things here. First of all, one thing I want to point out is we almost can't even see where the aortic knob is, but we can see this bump here, which is the left atrium. We also see here, interestingly enough, almost like a double sign, which again shows that the left atrium is enlarged. Now, I'm not asking you to read x-rays at all, but it just kind of makes this, I think, a little bit more interesting. If you turn and you compare the image to the left to the right, what I've tried to do is overlay the structures here on this oblique and kind of give you an idea of where things are, for example, here. So they talk about the right ventricular outflow tract is convex, okay? In this case, that's what they're referring to right here. Remember now, this is the anterior surface. So we're going from right ventricle here up into the pulmonary artery here, okay? And up in here, we're not seeing much of any of the aorta here. A lot of this has to do with the fact of the previous image where it's sort of obscured because the left atrium is enlarged. Now the left atrium, remember, is really back in here. And as you can see, in this one here, which is relatively normal, it's pretty much off of the spine. Here, on the other hand, it is displaced because the left atrium is so big. It's displacing it. Okay, yes, by the way, the outflow tract is really kind of part of the right ventricle, either right or left ventricle on its way to its artery. Okay, so here's another example of looking at an oblique from the opposite side. And in this particular case, we're looking again towards the right. And there is barium in there. You can see it kind of coming down. And you can see where it would be in relationship to the other structures. It's fairly straightforward. All right, now, I'll leave this to you when we'll, but strictly speaking, in terms of the four chambers, that's what you've got there. The two atria are back here, the two ventricles are back here, and that 6 is supposed to be on the septum right here. Okay. It's a good thing to know. Alright, this is showing you an MRI in the in the coronal projection. Now, I don't want to get into a real lot of heavy with all of this stuff here. So, but just briefly, I just want to call your attention again to the difference between the myocardium versus the right atrium versus the left ventricle. And if you've got the carousel of the heart, the right ventricle, remember, is anterior, the left atrium is posterior, the aorta is in between with the right atrium and the left ventricle. If that's the case, if you take a coronal slice in the middle of the heart, you should expect to include the right atrium and the left ventricle. That's supposed to be left ventricle, I'm sorry. And that's indeed the case here, between right atrium, left ventricle. There's the origins of the heart. This is further back posterior, and in fact where we are is in that left atrium. So we're actually on a plane that's back in here. So you can use the carousel of the heart as a road map. Okay, let's go all the way back. Now, this is from another website. As you can see, it's Kansas University Medical Center. We are way, way back posterior. In fact, you can see where all of the spine is here. I'm not asking you yet again to memorize these things. I just want to show you some of this. In the back is the descending aorta. And what we're doing is we're going from posterior to anterior. So notice what's happening here. There is the aorta. In fact, there's the aortic knob that you can identify on a chest x-ray. We are also at the same time looking at portions way back in here of bronchi. Now, with this particular MRI, air and moving blood are showing up the same. So there is the carina, for example, in the left main stem bronchi. At the same time, pulmonary arteries. Remember, all this stuff is going towards the hilum of the lungs. And we're getting into the left atrium. And from the left atrium, we're going to start moving further anterior. This is all pulmonary artery here. Now we're starting to move from there into the, there you go, right atrium here versus left ventricle. And you can see where the aorta is. That's coming down up this way. And I'm just going to kind of move this forward. So if you're on the point of the carousel of the heart, you can see that you should see on a coronal the right atrium and the left ventricle at the same time, much as you're seeing here. Now, if you recall, I was talking about the Doppler effect being recorded on an ultrasound. Well, it's not exactly Doppler, but something rather similar happens with MRI in certain sequences that they do. And specifically what I'm talking about here is that blood flowing in the normal projection shows up as bright. On the other hand, blood that's flowing in the wrong direction is showing up as dark, because really what's happening is it's not showing up at all. So what you are seeing here is the aortic valve. You can see how it opens, closes, and what's happening is it's not closing properly. So blood from the aorta is leaking back into the left atrium. We call that aortic regurgitation. It's going backwards. It's going in a retrograde manner. Obviously, that's going to make the heart work that much harder. And this is just kind of a stationary picture, and there's where you can see the aortic valve actually is. Now that's close between the junction between the left ventricle and the aorta itself. I just wanted to show you the short axis, mostly because we were talking about the long axis, and this is a different plane. Now, you guys are familiar with the coronal plane, I assume the sagittal plane, and certainly the axial plane. This is a double oblique, and what they are trying to do really is to show the entirety of the myocardium surrounding the left ventricle, because that's where a lot of the cardiac damage is actually located. Okay, let me back this up. Sorry about that. Okay, the short axis is another example of a plane that is used more by the cardiologists than, and is not something typically we kind of think of. Put it this way, I think this really has stemmed from nuclear medicine more and echocardiography. The reason MRI and to a lesser degree CT do this is because, again, the people that are looking at this are the cardiologists. So we're looking at predominantly here now around the left ventricle. Now notice this is the anterior surface. That means over in here. This is the anterior surface. Remember that. That's one reason why it looks a little cattywampus. And this is the way the angle is actually set up. So as you can imagine, it's not going to look like something you typically see daily. And when you look at it from an MRI perspective, this is actually demonstrating it in part. And specifically, you're looking at the right ventricle here and the outflow tract. There is the septum, and there is the left ventricle. So really what we're mostly interested in is the state of the myocardium, here versus here versus here. Now the rest of this is probably impossible to try to figure out. Somewhere in here is where the sternum is. So the rest, as I said, it's a double oblique, so don't try to wrap your head around it. It's probably not worth it. Here's another one, and it's outlining actually some of the blood vessels. So for example, there are the anterior descending arteries and veins. Here's still the septa, and again, gives you a nice view of the damage, if there is any damage, to the left ventricle. Now here, this is another city. This is still an MRI. Notice, by the way, that the blood is now looking bright. one of the things I think I need to kind of point out is MRI those images are acquired using what they call different sequences. The sequences are related to the time of acquisition and to whatever point in the kind of spin of the hydrogen atoms. You can have situations like this where blood is showing up as bright. You can have other situations like this where blood is showing up as dark. This has nothing to do with contrast media. This is simply the way that the MRIs are acquired. Now, you can see the heart is beating, and that indeed is exactly what goes on. The whole point behind the contraction now is evaluating ejection fraction, and the efficiency of the left ventricle in pushing blood outward. So what you're looking at is at the point of dilation, the maximum amount of blood that's possible, at the point of contraction, the maximum amount that has been pushed out. If you calculate the difference between them, that's how you come up with the ejection fraction. All right, here's an example of a nuclear medicine SPECT scan, and the reason that you're seeing the little kind of roundabouts here is because you're looking at things from a short axis perspective. So if we use this one here, you can see there is the right ventricle side there, and this is the left ventricle side here, much like the previous MRIs. Again, it's a totally different imaging modality, but it's using the same plane. And how about this one here? Here's another type of a radionuclide, where you are seeing the left ventricle as it's contracting. The inside is looking bright, the outside is where the myocardium and everything is. It's kind of on the periphery here. We're just watching it beat.